All right, welcome to chapter 14, Methods of Therapy. Here we go. All right, so here's our first four learning outcomes, and then followed by our next four learning outcomes. And so we're going to go through all these different therapies rather quickly, but just to make sure that you understand kind of some key points to these therapies and the differences between them. So when we talk about therapy, generally speaking, we're talking about how do we address and from what angle of attack do we approach different disorders, different things like depression, and the way that you believe or your worldview, your psychological worldview of how people are, whether they're inherently good, whether they're inherently blank slates, whether you can have some innate sin, like original sin or not, be a part of your being, will change how you approach someone in therapy. Okay, so when it comes to psychotherapy, there are different types of psychotherapy that exist. Namely, you can see that it's a system of interaction between client and therapist. Some are based on, you know, psychology theory and like the research that's done around that theory. Others is, well, what are the client's thoughts and feelings and behaviors, and how does that guide the relationship between the therapist and the client? And what about those individuals who have, mental health disorders, psychological disorders? How do we address those individuals? And does that look different than if you have an individual who is coming into psychotherapy for more day-to-day type struggles that aren't into the psychopathy realm, right? There's still struggles and still distressing, you know, how do I handle my anxiety, right? And it might not be general anxiety disorder, but just these minor anxieties. And so you can see it's going to shift and adjust and change depending on the circumstance. When it comes to the history of these things, in the past, treatments, as you can read there, of psychological disorders were often worse than the conditions. And we're going to talk about some really crazy things that they used to do, okay? Starting with asylums. Now, originating in Europe, what's really interesting here is that their function was to primarily just house individuals with psychological disorders. Yikes. And so you had all these people in these insane asylums, and patients were mistreated and victimized. And so reform movements by Philippe Pinel, as well as William Tuke of England, and then Dorothy Dix of the United States, really aimed to change that, right? That they weren't these places where people went and were just stationed there, but let's reform them to have this humane treatment. And part of that reform was trying to get them into these mental hospitals or institutions to try and treat those mental disorders, okay? You can see this one hospital in Saskatchewan here. And what's interesting is that these hospitals really turned into more of those asylum type places, okay? That these individuals went there and they sought after treatment, but what happened is that 90% of the hospitalizations of a psychiatric disorder occurred in a general hospital, and these hospitals weren't really and the people in them weren't really well equipped for distinguishing whether one person was sane versus not, to what degree can we let them go and when, to what degree do we need to do different therapies in there, and what does that look like? And so it was really poorly equipped, not unlike from the research paper that some of you read, insane versus sane, right? Where they had the pseudo patients go into these types of places. So these people were normal, healthy individuals, and they went in with um, um, this idea of having hallucinations and delusions, but they actually didn't have them. Yeah, that's a problem, right? Because the therapist couldn't tell the difference. Um, so what we transitioned from those into this community mental health model in the 70s with the two primary goals of to treat these psychological disorders within community, right? We don't want to pull them out and put them in a box. We really want to treat them where they are at and have the community supports to enable them to be successful in those communities. Okay. In those communities, we need to provide community members with mental health education and resources. That's where this has fallen flat. Okay. That has not happened well. And we can critique that, right? We've now lived, 60 years with this, and it has not gone well. Um, and so we need to look to what's happening, because often ex-patients or ex-addicts, would now work in, they're called paraprofessionals, would work in that field in the supervision of a professional to try and help those individuals with their mental health problems, and that system still has not been able to function to its maximum, right? To its full ability or extent. Going back a little bit more in the history, we've got these psychoanalytic therapies, which started with Freud and this idea of we're going to review your dreams and those types of things, dreams analysis, and have this idea of, you know, free association, because Freud didn't believe free association was actually free. He assumed that those free moments are actually something that's coming from deep within, right? That you're being pushed to think in these free ways, and then that will tell us something about your motives and your incentives and your drives and those types of things. Okay, but the aim was to strengthen the ego. So remember, it's a Freud thing, so that you can sufficiently manage the demands of that ego. And so this free association, sometimes they would allow that id to come to the surface a little bit more, and that dream therapy would allow that id to come to the surface a little bit more. And you would discuss those things. And then the big thing here is that the therapist is the expert. And so the therapist would be doing the interpretation of what's going on. And so the therapist would provide that insight. We have a couple of principles here, catharsis being the release of emotional energy after a traumatic experience, this free association, like I've alluded to, uncensored utterings of thought that come to mind and allow, the analyst, and that, once again, that's a key part, to get some insight into the patient's unconsciousness. And then we have this idea of resistance, okay, or the tendency to block that free expression of impulses and ideas. And so the therapist would actually watch what you were doing and how you were saying things. And if they sensed resistance, okay, that they would recognize that as a patient is close to accessing this unconscious conflict or repressed memory for that matter. Okay. Now, when it comes to transference under the psychoanalytic perspective and of therapy, transference is where responding to one person in a way that's similar that one would respond to another. So I would respond to, if I was in therapy, I would respond to the therapist as if they were perhaps the person that I was struggling with, like a parent or a sibling or some other individual. And what they found was that can happen from the patient to the therapist, and if it happens from the therapist to the patient, that's called countertransference. Okay. And what's interesting is that because Freud is so focused, and Neo-Freudians are so focused on that early childhood or that developmental part, especially before age 6, then we have this idea that the problems or the conflict that exist will most likely be with your parents at that stage. And so you're going to try and reenact your childhood and conflicts with your parents. in therapy. I've alluded to dream analysis, this um, ability to access the unconscious. And we've got this wish fulfillment where, your unconscious impulses are expressed in dreams. Okay. And so then you would talk about that wish fulfillment. Well, why do you think that you should do those things or these other things? And then remember the analyst, the therapist or analyst, would interpret what you need to do, okay, or what it means. And so the psychodynamic theory or therapy, once again, based on those principles of psychoanalysis, but it would be a lot shorter. So for psychoanalysis and that type of therapy, long and thorough and frequent therapy sessions, like you're coming, 2 to 3 times a week for years. All right. And so the psychodynamic therapy would say, well, you're going to come a little bit less than the psychoanalysis, okay? And what's interesting is that the therapist does still occupy that directive role, and that's really important for this type of therapy. Now we have interpersonal psychotherapy, which focuses on the client's current relationship rather than their childhoods. And so you're going to be working through emotional situations that are in the present, not necessarily in the past. So that's a slight shift from what we've already learned. Now, when we come to humanistic therapies, these therapies are really focused on the client's subjective and conscious experience, okay? What are you experiencing now, like here and right now? And what I find really fascinating is about 31% of Canadian psychologists who practice psychotherapy take the humanistic approach, all right? And it's somewhat based a lot. So when I was back in getting a minor in counseling, and which I didn't get a full minor, I got just most of it. Anyways, and so what happened was it was really focused on this client-centered therapy. They pushed this a lot, where Rogers believed that self-actualization or this desire to reach one's full potential is an innate human instinct, and as a result, roadblocks or things that got in your way to this path of self-actualization cause those psychological problems. Okay, what's really interesting is failing to get unconditional positive regard. Okay, which means that regardless of what your behavior is, you're still accepted as a good human being deep down, will affect your own belief about your own potential. And so one thing that the therapists in this client-centered therapy would do is that they would look to the self-exploration and self-expression, trying to understand where their level of regard is, because the therapist is trying to repair the damage of that unconditional positive regard. Okay, that's one of the pieces of this client-centered therapy. So how do we do this? Well, it's a non-directive approach. All right, so the therapy sessions are going to be the client-driven or client-guided approach. And essentially the clients will arrive at their own decisions, right? You're not making decisions for them, but they are indeed making them for themselves. And so as the therapist, you're going to be sitting there trying to be full of empathy and genuineness. Those are hugely important, that you are absolutely genuine. But it's kind of like, if somebody comes and sits in and I'm the therapist and they say, well, I'm having problems with my level of stress, and so I, as the therapist, would reflect on that in this way. I would say, well, I hear that you're having problems with managing your levels of stress. It's like, yeah, and then so it bounces back to the person. Yeah, I really am struggling with my day-to-day. I don't know how to schedule my life. I feel like overwhelmed because there's too much going on. And then the therapist would reflect and say, I hear that because there's a lot to manage in your day, that's overwhelming. And so you're aiming to find better solutions to manage your daily activities, right? And you can hear how it's just a little bit of a tennis match, hitting a ball back and forth, and ultimately the ball always ends back up in the patient's or the client's court. Okay. When it comes to Gestalt therapy, this assumes that people are experiencing conflict and psychological conflict because they're not accepting their whole selves, the good and the bad. And so the things that are going to be met with social disapproval are rejected. Okay? Now, that can be really damaging because, according to Gestalt therapy, you need to accept your whole self in order for you to be able to make changes to any particular part of yourself, and in a non-judgmental way, right? It's I can see the whole picture of myself, therefore I want to focus on these aspects and then, maybe adjust these other ones. And for this goal-oriented type of behavior. And so it aims to help individuals integrate these conflicting parts into their personalities, and uses a directive method. Once again, the therapist is now directing this session to help the clients perceive themselves as a whole. And I remember going through a therapy session like this, and it was so funny because the therapist just got up in my face, right in my face, and he goes, "What do you want to be?" I'm like, whoa. This type of person, if you do, you have to be accepting of your whole self, all the good, all the bad. I'm like, whoa. It was right up in my face, somewhat antagonistic, but that's one style of this Gestalt therapy. When it comes to behavioral therapy, this is also called behavior modification. So what we're trying to do is, these therapists believe that your behavior can be adjusted because everything is learned, and so everything can be unlearned, or you can learn new things. And as a result, we're trying to promote learning, we're trying to promote your direct consciousness of those behaviors and help you discontinue those self-defeating behaviors by adapting patterns that are more that promote further the beneficial actions that you want, right? And so that's what they're going to look on it and use conditional, and observational learning, rewards and punishments, those types of things, to enable you to be able to overcome maybe fears or other types of things like that. And one part of that is this fear reduction method for phobias and for things that you struggle with, but in particular phobias. And so one method that they would use is this systematic desensitization, which, like you can read here, developed by Wolf. And what he found was that there's this idea of hierarchy. Okay, so you're arranging stimuli according to the amount of fear they invoke. And so what you would do in a session is that you would, for example, confront the hierarchy, and you would start small. So first, if you're afraid of spiders, first I want you just to think of a spider. Then I want you to look at a picture of a spider, right? Then I want you to hold the picture of a spider. Then I want you to be in a room with a spider. The spider's way over there, but I want you to be in the same room. Okay. Then eventually I want you to hold the spider. And that's called, confronting that hierarchy. And then we get into another thing called counter conditioning, which is teaching that client to use deep muscle relaxation as a part of the routine, so that they will then use that when confronting the hierarchy stimuli. Okay, so we have that stimuli that's triggering that stress response, and if you can focus on that deep muscle relaxation, then you're reducing the stimulus effect. Okay. This can also be used for fear of needles, and fear reduction methods can also use other techniques such as uh, virtual therapy. So what you would do is same type of scenario except for in virtual reality, right? So in a graded fashion to help them confront that fear, but in like a virtual reality type scenario. Um, and then there's this flooding technique where we're just gonna literally put you in a room full of spiders, and it's like, go. That's called flooding. Might not be so good. Um, Interesting is that individuals who developed an intense PTSD because of something like the World Trade Center, one thing that individuals would do is that they would be shown, or you would talk about what happened there, and then they would be shown this picture, and then maybe gradually get closer to even the area itself, to once again help reduce the fear of what happened in that scenario. And like I said, same thing with spiders here. This one is using that virtual therapy where you can see the headset there, and you can see the tarantula also being present, and they have to touch it. Yikes, right? But works really well for some clients, right? This is why we have a variety of therapies, because it doesn't always work for every client. Another fear reduction technique is this idea of modeling. And so the client is going to observe and imitate a person who approaches and copes with the object or situation that they fear. This works really well with snakes. And so if we have a fear of snakes, which the majority of us are born with, then watching someone handle a snake well, non-venomous kinds, garter snakes, those types of things, and then you get to be exposed to that in a variety of degrees, but just watching that, and then this is how you cope, and this is how you handle, and this is how you manipulate in a positive way. It really helps in the ability to increase self-efficacy when you're trying to manage that fear. Another principle based on classical conditioning is this aversive conditioning. So you look to the undesired responses as things that are inhibiting, and so we can actually inhibit them by pairing repugnant and offensive stimuli with them. So maybe you were one of those kids that were caught smoking, right? Like a little kid, and then your dad or whoever says, "Kate, you're smoking the whole pack," and you just got to chain smoke that whole pack. Or you smoked a cigar, and they're like, "Okay, now you're chewing it and eating it and swallowing it," right? Like, so that's aversive conditioning. Interesting is that this might also be the same reason why you don't like chicken noodle soup. If you had that every time you got sick, okay? Um, the next one is operant conditioning principles. So we're going to want to have uh, promote some behaviors and extinguish other behaviors, and use principles of reinforcement and punishment to do so. And so one way that we can do that is through this token economy. So people are reinforced for behaviors that are desired. And this works, interestingly enough. I like to do this with my little ones, because I can say, if you complete this task, you get this many points. And those points, once you get so many of those, then you actually can go buy a toy or have an activity or watch a movie or whatever those are assigned to. And then he can use those, or they can use those tokens to pay for something else, right? Which is really neat. And then there's another one called successive approximations, where it's a series of progressive behaviors that are systematically reinforced until the target behavior is achieved. So this works well for things like potty training. If you want them to eventually go to the toilet, well, if they tell you that they want to go to the toilet, then you reward that, right, at the beginning. And then you increase that that behavior that they have to accomplish. So they tell you, and then they go to the bathroom. Now they're rewarded once they go to the bathroom. They tell you, they go to the bathroom, and they take their pants off, right? And you're like, okay, whew, nailed it. And then, tell you, run to the bathroom, take their pants off, hop on the toilet, okay? And you can see how those successive approximations would really help to help encourage those positive behaviors that you want to engage in, right? And this works with therapy too. If you need to have a certain goal accomplished, if you fear driving, okay, and you have to drive to work to get to work, well, then you might use successive approximations. We're gonna walk to the car, okay? You got to the car, great. Now you're gonna walk to the car and get in. Okay, so you walk to the car, you get in, and you sit down. You're like, whew. You walk to the car. So that's number 2. Walk to the car, get in, sit down, turn on the car. Walk to the car, turn on, sit in, turn on the car, and then back it up. Okay, and so you can see how that would build those behaviors that you want to keep. And then we have this biofeedback training, which is providing bodily function so the person can gain control of that. So this is the control your breathing. Like if you have somebody who really struggles with anger, you're like, whoa, breathe, like focus. I need you to focus on how you're breathing, control that. And then they just start to, pretend like you're blowing up a balloon or blowing a bubble with bubble gum, right? And so you're learning how to control that biology, and then that feedback will tell your body, okay, we need to calm down here. That's the biofeedback training. When it comes to eye movement and desensitization and reprocessing, so EMDR, this is therapy used to treat stress and stress disorders, things that clients will help, you follow a moving finger while keeping the trauma in their mind. Research suggests and shows that EMDR decreases the anxiety with traumatic events. And so it could be, that eye movement piece that they're focusing on here. Sometimes they'll do tapping from, one leg to the next. It's the same basic principle, though, in trying to engage both sides of the brain and dealing with the trauma or anxiety that you're facing. Trying to get that corpus callosum to be, let's pass this information back and forth. But what's interesting is, like you can see for the critics, is that it doesn't necessarily need the eye movement to be a part of it, but you can even employ tapping your feet techniques to achieve a similar goal with this type of processing. You're just trying to get both hemispheres to work. And this is also why I would suggest that if you are really stressed or something, some thought is anxiety provoking, go for a walk. Like and think about that thought. Because what are your feet doing? Yeah, left, right, left, right, left, right, left, right, right? And so that's how you can be more successful in solving those types of problems, getting through those types of anxieties. Go for a walk. When it comes to social skills training, we have these therapies that decrease the social anxiety and build skills through operant conditioning procedures. Self-monitoring is you are, as the client, are tracking your own behavior. Behavioral rehearsal is practicing those skills, okay? Coaching is when the therapist or a mentor will tell you what to do next, okay? Modeling, we've talked about that before. Role play is a really powerful one, especially when there's a situation that you have an idea of how it flows, but you want it to flow differently, okay? And so then you can actively engage with your therapist, or if you're the therapist with the client, in a meaningful way and they can look for alternate solutions to that problem, which is really good at building social skills. And then feedback, right? So the client's receiving this constructive information about the effectiveness and appropriateness of their own behavior and how to address other people's behavior as well. So that's behavioral therapists. Now we're going to get into cognitive therapists, and these cognitive therapists focus on how clients, cognitions, right, thoughts, expectations, attitudes, beliefs, lead to distress. So is it because you're ruminating about something that it's a problem? Is it because that you consistently think about the same solution to that problem? Or can we allow you and prompt you to think differently, so that the goal of this therapy ultimately is to modify those conditions of thought to alleviate distress, okay, and promote more adaptive behaviors. Now, it was good old Aaron Beck and Albert Ellis who spearheaded this type of therapy, and it encourages clients to be aware and gain awareness of the current thinking process and how you think irrationally. Okay, a lot of Beck's work is on this irrational type behavior, that you think irrationally, that therefore you are going to have problematic solutions to the problems that you are facing. One irrational thought is selective perception. For example, an anxious person may perceive the world as a dangerous place. So what they are doing here is they are selectively remembering the evidence that tells them that the world is a dangerous place, although it's might not be for them, especially when they're just straight up ignoring evidence to the contrary. Okay, overgeneralization. This is maybe a depressed person might assume that because the last partner cheated on them, or sorry, the last partner cheated on them, the next one will cheat on them. So that's overgeneralization, okay? And so it's not selected to just the one person, but that the next person, or any person for that matter, is going to in some way be not trusted or trustworthy. Then we get to magnification, which is where the anxious person might actually blow an event out of proportion. So if you think that you're going to fail this course because you failed an exam, and then you failing this course leads to you're not going to amount to anything and you'll end up homeless, that's some error in cognition. That's some irrational thoughts, okay? And then we have this absolutist thinking where, once again, sticking with depression, maybe an individual will conclude that because they're not perfect, they are terrible, okay? And that kind of goes down that perfectionistic vein that we were talking about, and how that perfectionism can lead to depression and other types of things as well. And so what you can do is, these two most common irrational beliefs that people might have need to be alleviated, right? Removed. And the two most common irrational beliefs, and if you remember the chapter that had that whole page, that whole chart on irrational beliefs, this comes from that chart. But one is that you must receive love and approval from others, and two, you must prove oneself to be confident and adequate in achieving. Well, what happens with that is that you have to remove those irrational beliefs from your cognition. And Albert Ellis developed this rational emotive behavioral therapy to help shape people's responses and their belief system. And what the therapist's role in this REBT is to look at what the client is saying and challenge and correct these irrational behaviors and beliefs. It also can incorporate Ellis's therapy, those ABCs of the experience, where you have an activating event, an irrational belief, and then a negative consequence associated with that event. And so as a result, he would employ well, let's look for what that activating experience is. Let's address what that irrational belief is. And then let's talk about those negative consequences and rethink about the situation. Okay? Use some cognitive behavioral therapy towards that. And what you're doing here is you're actually integrating, and not only just the thought process, but the behavioral aspect of therapy into trying to solve the situation or problem that you are going through. And so what's interesting, and what's really interesting, is that it has been deemed in a lot of circles of therapy as the most successful type of therapy, generally speaking. Okay, so 4 out of 5 Canadian psychologists identify as CBT, and they see, results, successful results around the 80% mark, which is amazing. Okay, and they use this the dialectic behavioral therapy. Okay, for a few things, but especially for borderline personality disorder. So when you think dialectic behavioral therapy, think borderline personality disorder. It's effective for that. Or it's the most effective therapy for that, I should say. So when it comes to group therapies, let's all sit in a group and see if we can get through our problems together, because we know that groups are really significant. And when you're a part of a group, you have better social supports, and those social supports can lead you to different behaviors. You can also potentially conform to better behaviors because of the group that you're a part of. Think of the Ash's line experiment, right? We're talking about lines and people are conforming to that. And so why not conform to these better ways of thinking and these better ways of doing and being? And so the advantages is it's economical, because there's a group of you paying for one therapist. More experiences for the client to learn from. So if I'm going through something and I hear that somebody else is going through something very similar, not exact, but similar, I can feel, oh, I'm not alone in this. Okay. And so that social support of the group can grow. And then, it provides an opportunity to practice not only in relating to others, but to practice how to improve through role play even. So it can become really foundational and helpful for that purpose. But a disadvantage is that, maybe clients are going to be unwilling to disclose or express their true feelings about what they're going through. And you're in a group. You have to trust the group to not say, oh, I know this person and they're going through hard things, and so I'm going to exploit that. It's like, that's not very good. And perhaps your experience is just a little bit similar to those of the group, but not enough to have a supportive reception from the group, and so that you might feel isolated. That can be a disadvantage. Another type of therapy is couple therapy, helping relationships become enhanced through better management of conflict. That's a big thing when it comes to couple therapy. And then later on, when we talk about family therapy, is how do we resolve conflict? What are the methods employed there? So as a part of couple therapy, one thing that they focus on is communication skills, like how to listen and how to express feelings, right? How to handle things like depression and anger, and how to solve problems. And so when it comes to this family therapy, you go as a family and you talk about, once again, it's probably a communication problem. And so you talk about those situations that are distressing, and how to adapt different patterns of interaction and communication to better solve those family problems and issues. And generally speaking, it promotes growth and autonomy of each family member, because from the littlest to the largest, everyone's opinion matters. Everyone's input matters in family therapy. So all ideas are heard, and no one is seen as better than others in family therapy, which enhances the functioning of the family. And once again, that autonomy of each member. So with all these therapies, do they work? Well, a meta-analysis, combining the average results of these different therapies show that psychotherapy is effective, that people who obtain psychotherapy fare better than those who don't, that with the different types of therapy, some of them are more effective for certain problems or certain types of people. So being well versed in these as a therapist is really important. And when you look to the psychoanalytic and client-centered therapies, more effective for well-educated, strongly motivated individuals who report problems with anxiety, depression, and interpersonal relationships. People with anxiety disorders, somatoform bulimia, show a better affinity towards cognitive behavioral therapy. That therapy specifically allows them to change their thought processes attached to things like food, right? Things like the situation that they're getting into, whatever environment is promoting that anxiety. But ultimately, therapies that increase positive emotion and social engagement have proven very well for combating depression. Okay, so we're trying to boost that positive energy. We're trying to boost that social structure, that support structure, and so yeah, it would then go, be supported that you got to go to your family social network or other social network to gain support for when you're sad, right? To reach out to them and say, hey, I'm struggling, and then have them take you out for ice cream or whatever it might be. Okay, but that social support's really important. When it comes to major depression, things like positive psychology and traditional psychotherapies and medication work. What's interesting is that exercise has been shown to match or surpass psychotherapies and medication in the treatment of mild to moderate depression, which I love that stat. It's like, get away from the drugs, go for a run, okay? Go lift some weights, go do some yoga. If you're in that mild to moderate depressive stage, get out and do something, get active. Now, when it comes to children diagnosed with autism, they actually show improvements when you engage in those behavioral therapy components. And think about what autism entails, right? What that thought process is like. If you go back to chapter 13 and review that, this should make sense, right? So when we look to this table here, this is found in your textbook. So make sure you review this table. You might see some of those things on the exam. Okay. Now, when it comes to race and ethnicity, members of certain ethnic or cultural groups, once again, the psychotherapy methods that we've previously discussed might not work for certain cultural groups. That's a very Western context type therapies, and we're not talking about more indigenous populations or collectivistic cultures, okay? And so they might work a little bit, but the problem is that the therapist might lack information about that person and their culture to really be helpful, okay? And so the culture in and of themselves might distrust professionals, which is a problem. And so when we look to psychotherapy in ethnic or cultural groups, we have to pay attention to language. Pay attention to language, because if I can't communicate well to you the problems that I have because you don't speak my language, then the therapy session isn't going to work, right? Like, we can't get down to the meat and potatoes of what actually is going on. All right. Also, what type of problem-solving approaches do different cultures take? If you don't understand those different problem-solving aspects, and there's been lots of research done on how collectivistic cultures look at certain pictures and how the focus of art is different in a collectivistic culture versus an individualistic culture, in a Western culture versus an Eastern culture. And this is interesting because even the focus on something as simple as art and how that differs from culture to culture is indicative of how people are going to try and problem solve, right? And what aspects of the problem do they see? And so when it comes to therapy, that's going to be hugely important to know that, so that you can be able to understand what approach they're going to be taking and what thought process they're going to be having, right? What synapses are going to be firing towards a therapist or therapy in general. And so when it comes to the stats on Indigenous Canadians specifically, there is this huge loss of culture and identity. And so as a result, Western contextual therapies are not going to be as effective for them because it doesn't embrace their values. It doesn't embrace their customs. And so those things need to be addressed when in the therapy session. And one thing that I really appreciate is, that's the statute you're reading here is from 2013. There's, especially in the last 5 years, there's been a huge push to have Indigenous focused counseling and healing and mentoring for a therapy session specifically, right? Which I find fascinating and fantastic. Asian Canadians tend to stigmatize people, or not specifically, but stigmatizing people with psychological disorders is a more, well, according to the stats from this textbook, we'll put it that way, a more Asian Canadian type thing. And what I find really interesting is that if you have a problem, then you will most likely deny it and refuse to seek help, okay? Because it's frowned upon. It's hugely frowned upon in that culture. And you could be denying like painful thoughts or experiences and then experience something called a somatoform, right? Or that somatic syndrome. And so your body is having a physical reaction to something that's going on in your brain that really isn't connected, or that shouldn't be connected. Like your leg stops working. It's like, what just happened? Okay. And so those things do occur. And so need to be addressed appropriately. Now, when it comes to Black Canadians, they do face, prejudice and discrimination. So why are they going to go seek help, especially from a white counselor, right? And so because of cultural assumptions and stigma and mistrust and racism and discrimination, there's a decreased likelihood, at least according to the stats, that they're going to go in and seek help, especially from a non-ethnic or an ethnically diverse person. Okay, and once again, these stats are a little bit older, and so we're seeing a shift, but it still does persist today. We've talked a little bit about individualism versus collectivism, so I won't get too much into it here. Because one thing that I want to get to in the last 10 minutes is these first responders, okay? So what's interesting is that 45%, 44.5% of first responders report clinical symptoms of mental health disorders, including PTSD. And we've talked about mental health in first responders in the past, so this shouldn't be a new thing to you, but these are individuals like police and paramedics and firefighters and 911 operators, okay? So this subgroup really deserves some special attention when it comes to mental health disorders, and therapy and how you address therapy, okay? And so what's interesting is that we use some biological therapies to help these individuals, especially those who work in that type of field, okay? And so with biological therapies, what we're trying to do is, know your biology, and perhaps involve some drug therapy, or electroconvulsive therapy or psychosurgery. When we talk about drug therapy, this is for anti-anxiety drugs. These are things like your benzodiazepines, okay? Prescribed for general anxiety and panic attacks. They're going to help decrease the sympathetic nervous system activity. These are downers, okay? And so what can happen is this side effect, okay? So sedation is a common side effect and can cause something called rebound anxiety, which means that you take the drug and then as you're coming off, you actually feel more anxious, which can be really problematic and quite distressing, okay? So here's a table of the drugs used to reduce anxiety, things like Valium, and then for depression, we've got Prozac, and reducing delusions and hallucinations. You can see, Prolix, Prolicin. Anyways, when you look to these drugs, make sure that you know a couple, right, in each category, that you know what's going on for the most commonly prescribed drugs, because they are widely out there, and as a result, are probably the drugs that are being, the prescription drugs that are being abused as well, right? It's not uncommon to have a significant other, friend, family member, whatever, who's on drugs, and then people to be like, ooh, I want to try that, like that, and that's hugely problematic, okay? So when it comes to antipsychotic drugs, these are major tranquilizers, okay? The Thorazine is used to treat schizophrenia, and what they are thought to do is to block dopamine receptors in the brain. So when you think of someone like schizophrenia, and the dopamine theory of schizophrenia, meaning that those who are schizophrenic utilize more dopamine than normal, non-schizophrenic individuals. So what you want to do is you want to block dopamine receptors. You don't want as much dopamine going through, because that's the thing that's creating the problem, and that's what these antipsychotic drugs will do. Now here's the thing with antipsychotic drugs, though, is once you get on them, you can't get off them, all right? It's not easy, anyways. Can't say can't, but likelihood is super small, because of the nature of what they do to your body. All right. Then you get into these things called antidepressants, which are, and we've talked a lot about this in class, the selective serotonin reuptake inhibitors. Saw the diagram in class, right? And so when you look to things like Prozac or Zoloft, these are going to increase the serotonin levels in your body. Okay. Now, we talked about in class, or at least in one of the sections, where one individual who went on an SSRI, and this particular individual, as they went on this SSRI, they had an increase in serotonin levels, and they also had an increase in delusions and hallucinations. It's like, what? So this is why these drugs can be, well, they are going to be very impactful, for the most part, and have to be treated with a lot of caution, or else it can be really problematic. Another drug used is lithium, Now, lithium is derived from the metal lithium and is prescribed for bipolar. So anytime I've brought up a drug, once again, make sure that you know the thing that it's used to treat. And what happens with lithium is that people can have, so we're trying to level out your mood, right? Like you've been woo for bipolar, and we're trying to just mellow that out. And so as a result, one thing that can happen is you can have memory impairment. You can have things like hand tremors, or some possible side effects to lithium. But that's, once again, that's the purpose of lithium, is to take these huge mood swings that you're facing and to mellow those. If you go on lithium, once again, it's going to be hard to get off. Now, the question is, with all these drugs, does it work? Well, the interesting thing is that the answer is sometimes, okay? So it can be really effective, but it's not always really effective. The specific drug might not be really effective. The group of drugs, right, SSRIs might be effective, but the particular SSRI for you isn't as effective. And so this is why we have drug therapy and exchanging of drug type and those type and dosage and all those types of things, okay? Most problems, though, related to drugs concern their side effects, those memory impairment pieces, okay? When it comes to things like antidepressants, here's some crazy research, is that it came out stating that antidepressants are overprescribed. So somebody will come in and they might not have major depressive disorder. They might be just having a depressive moment, okay? And that moment might last a little bit longer than normal. But here's the thing, remember mild to moderate depression, like go for a walk? That's the solution, not the antidepressant. And so then they're overprescribed. And so that's can be hugely problematic. And so this is where when you are seeking medical advice and you're going to the doctor for depression, which do absolutely, talk with them about those non-drug therapies first and what that solution might look for you, okay? And then employ those things first, right? That should be your first step. And then if it is more severe, absolutely, you might need some medication to help with that. But once again, mild to moderate depression, like go and get some good exercise. Always, though, seek medical attention and help in those scenarios. When it comes to light therapy is super fascinating when it comes to individuals who suffer from seasonal affect disorder, okay? And so you're struggling, it's winter time, you live in Vancouver and there's no sun. And so what you do is you can use this light to actually help you treat those seasonal patterns of depression. It works fantastic, right? Just a few hours under the fake sunlight and whammo, you're feeling so much better, right? This is a non-drug therapy for those seasonal patterns of depression. And so, yeah, if you find that that's the case, is that, the winter blues come at you, go get one of these fancy lights. When it comes to other types of therapy, we have electroconvulsive therapy, which is passing an electric current through your head. Okay, not the first option, by the way. When you are treating depression or bipolar, this isn't the first option. This is we're getting to the latter stages of options now, because this is a majorly invasive thing to do, like passing current through your, trust me, I used to be an electrician, right? Like I know what it's like to have current run through your body. It doesn't feel so good, right? Maybe changes the way you think. But here's the crazy thing is that patients for this process are given a sedative, and then these electrodes are attached to their scalp, and it induces seizures. As a result, the side effect of this is memory loss. That should make sense, okay? Like shocking your brain. Transcranial magnetic stimulation involves, instead of an electric shock, it involves magnets, okay? And so we've got these little magnetic coils that are by your head. And it has fewer side effects than into your brain, but they are used to treat things like major depressive disorder, um, obsessive depressive disorder, and schizophrenia, okay? Because what we're doing with that, if you know anything about electricity and magnets, is that anytime that you have an electric current passing through a conductor, i.e. your nervous system, and then you put a magnet close to it, like you can alter that that current, right? You can increase or decrease it, which is quite fascinating. And so that's what they do in your brain, which is really cool. Another thing which is hugely invasive is psychosurgery. They don't do this so much anymore, okay, because this isn't good. But we've got this prefrontal lobotomy, and so they go in there, rip some parts out, which is really, really invasive and causes some extreme side effects, okay? And then we also have this deep brain stimulation. So this is where electrodes are placed and implanted into the brain. Okay, once again, invasive. But it's used to treat people with extreme depression, depression that doesn't respond to drugs anymore, or obsessive compulsive disorder. Okay, and there you have it. That is chapter 14 and the therapies for you to review. If you have any questions, please email me. But good luck studying.